Okay, so like I was saying, this is the seminar series, the first lecture. Harvard's also giving the same curriculum, and we're kind of working together to develop this. The overall goals are really just to learn the fundamentals, make sure that you have a good foundation so that you understand if you decide to go into radiation oncology what you're getting into. Also to help you understand what's going on in your clerkships, and then maybe to help ease the transition into your PGY 2-year. We'll kind of try to focus on the role of evidence-based medicine, help you take a full and complete oncologic history and physical, begin to formulate basic treatment plans for patients, and then this is the goals and expectations for the rotation, I should say, and then also gain exposure to radiation treatment planning. And so all of these you'll get from kind of observation in clinic, but then also hopefully from the lectures and the planning workshop and the journal club. And so specifically for this course, the first lecture is really going to help you understand the flow and structure of the clinic. A lot of this you may already kind of understand, but I think sometimes it helps to see it laid out kind of formally. The second lecture will go over more radiobiology and physics, and like kind of the important fundamental concepts that relate to the clinic. And then the journal club will kind of help you understand evidence-based medicine and also help you learn the basics of evaluating a radiation treatment plan. So like I said, 3 lectures. This is going to be background on fundamentals, and then the why and how of radiation, practical aspects, which will be kind of about simulation, patient mobilization, that kind of stuff, and then the planning workshop. And feel free to stop and ask questions along the way. Even though it's recording, it's okay. We can edit them out. And then I've tried to kind of put some cases on throughout the lectures as a theme. There's an early stage breast cancer case. This is very curable. Virtually everybody's cured who has early stage breast cancer, and so toxicity becomes a big issue. And can we scale back treatment? There's intermediate risk prostate cancer, which is still curable, but the prognosis maybe is not as good as very early stage breast cancer. And this, you can use different types of radiation. You can use external beam, brachytherapy, you can do surgery, you can add hormonal therapy. Glioblastoma, which is very poor prognosis, very aggressive. Even with surgery, chemo, and radiation, the overall survival at 5 years is 10% or less. That's probably a very optimistic number. And then bone metastases also, which is just a palliative treatment, but even for palliative treatment, there's evidence-based medicine to guide our decisions. We do radiation treatment plans, so you'll see kind of how everything applies to all these different treatment situations. All right, so first lecture. This is what we'll do today. So we'll kind of go through an overview of oncology, talk about what is radiation very briefly, kind of very basic physics, review a brief history of radiation oncology, and then the main focus is going to be understanding the patient care path, kind of what all the steps are to getting somebody to treatment and then through treatment, and discuss a little bit about radiation treatment modalities. And we'll go into this in more detail next lecture, I guess this Thursday. And then very brief discussion of evidence-based medicine and oncology. So let's do a brief overview of oncology, and I'm sure you guys know this, but just to kind of put radiation oncology into perspective, I think a lot of people outside of oncology don't realize that radiation is really one of the 3 major treatment options for cancer, and it's not an ancillary service. It's really a primary treatment for a lot of types of tumors. It plays just as important a role as surgery or chemotherapy in many different types of tumors and malignancies. But medical oncology still tends to be referred to as the patient's oncologist. And they use chemo, and they talk about liquid versus solid, which is like leukemia versus lung cancer. We tend to do less with the liquid tumors just because you can't treat the whole body with radiation, although we do some total body radiation. But I'd say most of our treatments focus more on the solid malignancies. And they do a 3-year internal medicine residency and then a 3-year fellowship. Surgical oncology, The classic surgical oncologist is a general surgeon that then does a fellowship in surgical oncology, but we also work with neurosurgeons, CT surgeons, colorectal, gyn-oncs, ortho. I mean, we really interact with all different surgical specialties, head and neck surgeons, ophthalmologists for doing eye plaques. And they have a variable amount of surgical training, and even the longest surgical oncology fellowships are only 3 years. Radiation oncology is 4 years of dedicated residency, so we like to say that we have actually the longest formal oncology training out of any oncologist. We're board certified to treat all sites and tumors, so we don't specialize just in, or we're not certified just to treat head and neck or breast or lung or GU. And we interact with, on a daily basis, physicians from all different specialties, so I think it's kind of a unique specialty in that sense. And then why do we give radiation? Actually, I don't know if you want to flip those two light switches down and put those two sliders up. It'll help us see the slides a little. Yeah, that's fine. So this is actually how I explain it to patients. I don't know what's going on over here, so I just look up. But when you have a tumor, you have the area of gross disease that you can see on a scan. You have microscopic extension coming out, and then you may have microscopic disease. So this could be like a glioblastoma. Surgery is easy to understand. You go in, you cut out the tumor, what you can see. But you may have stuff left behind, these microscopic extensions or distant metastases. So you can give chemotherapy, which kind of bathes the whole brain or in general sense the whole body, and hopefully gets rid of the microscopic disease that's elsewhere, and also will shrink down the microscopic extension, right? And so that's where radiation comes in, is it is really a local therapy, but you can cover regions around the surgical cavity or surgical bed, or in breast cancer, head and neck cancer, you can cover draining lymph node regions that have microscopic disease that you can't go in, or you can, but you have a high morbidity if you go in surgically and remove them all. And chemotherapy isn't really strong enough to get maybe some of the larger microscopic metastases. So I think radiation really complements surgery and chemotherapy very well. And there are certain tumors where we can treat we can treat it just with radiation alone. Radiation hopefully gets rid of that microscopic localized disease, and then you're left with no cancer, hopefully. So what is radiation? The definition, radiation is the action or process of radiating or emitting radiant energy. But it's really just, when we talk about radiation, it's a bunch of photons of different energy levels. So, you've already done rotations. You've probably heard about high energy photon beams versus low energy photon beams. They're all just electromagnetic waves that have different levels of energy. And so you probably remember from basic physics, the wavelength and the frequency are inversely proportional. So the longer the wavelength, the fewer cycles per second. And the higher the frequency, the higher the energy. So you can see short wavelength, 10 to the minus 13th, you have a very high frequency and a very high energy. And we treat cancer in the mega electron volt, so MeV range. So this would be up in the frequency or wavelength of therapeutic radiation. You can see X-rays or cosmic rays are up here. So 1.24 times 10 to the 7th would be what, about 10 MeV, right? 12 MeV. When you get down here, you're in visible light, and then down lower is microwaves, TV, radio waves, very long, low energy waves. Do you guys know what the difference is between a gamma ray and an X-ray? Any ideas?
Gamma rays are initiated in the nucleus.
Yeah.
X-rays are from the electrons.
Yeah, exactly. So they're actually, you can have a gamma ray and an X-ray that have exactly the same energy level. It's just a gamma ray, by definition, comes from internal, is generated internally by the nucleus, by nuclear decay, radioactive decay, whereas X-rays come from accelerating electrons that then bombard a target and emit bremsstrahlung X-rays, and we'll talk about that more on Thursday. So let's go over a brief history of radiation oncology. So this is kind of a cool specialty because unlike most specialties, we know the exact day and place that radiation was discovered and kind of born. And it's also pretty amazing if you look at how quickly it went from being discovered in 1895 to actually being used therapeutically. It was only like a couple months. And a little side note, it was the first place, there's the arguments about this, but a lot of people say that the first place radiation was used therapeutically was actually in Chicago. And Ralph Wexelbaum, our chair, is considered one of his titles is the head of the Chicago Radiologic Institute, I think, which traces all the way back to Emil Grubb, who treated the first patients with cancer. So it was up closer to downtown at the time, but it somehow over the years got folded in the University of Chicago. But Rankine discovered X-rays and won the Nobel Prize for this. Becquerel, very shortly thereafter, discovered natural radioactive decay. So these are a couple famous pictures from radiation oncology or radiology in general. This is Rankine's wife's hand, and this is her ring, and so this is the first X-ray image taken. And then this is from Becquerel's research. This is a piece of, I believe, uranium that he put on some photochromic film, and under one of these he put this is a Maltese cross, so you can see the cross here, and that's one of those crosses with like the arms that get wide as you go out. So here's the arms getting wide. But this was one of his first observations, that there was this radiation being emitted from a natural source. Marie Curie is obviously a very famous scientist, but a lot of what she did was isolate different radioactive isotopes. And she won the Nobel Prize along with her husband Pierre, and then their daughter also won the Nobel Prize. She won 2 Nobel Prizes, I believe. And then, yeah, like I said, very shortly after Rankine published his discovery, they were already starting to try treating cancer in Chicago. Interesting side note about X-rays: Thomas Edison was displaying an X-ray prototype machine at the World's Fair in 1901, and McKinley was shot on the other side of the fair. And there's some people speculate that had they done an X-ray, they may have been able to find the bullet, maybe save his life, but they didn't want to put him at risk. They didn't know what the X-ray machine would do to him, and so they didn't do an X-ray. But it's kind of an interesting thing. And then in 1952, the first linear accelerator was developed. I think it was actually developed overseas in Britain, I believe, and then in 1957 it was developed here. And that really revolutionized, kind of brought us into the modern era of high-energy X-ray treatment. Prior to that, they were really limited by using cobalt, and even before that, just radium, which has a much lower energy. So it's hard to treat deep tumors without a lot of surface toxicity, and we'll talk about why in a later lecture. And then radiosurgery was invented in 1968 by Lars Leksell in Sweden. And that's the gamma knife, was really the main modality for a long time, but we're now doing that with linear accelerators and CyberKnife and other modalities. It's kind of amazing to think that they were doing radiosurgery before the CT scan was developed. So they were localizing intracranial targets just based on symptoms and X-ray imaging, treating acoustic aromas or brainstem tumors or different things. Toxicity was much higher, obviously, but it's kind of amazing to think they're doing that. And then in the 1980s, multi-leaf collimators, which is what allows us to do IMRT, were developed. Proton therapy came on the scene. And in the late 80s, IMRT, or intensity modulated radiation, first was developed, and that's really exploded, and really everybody, I think now, any radiation oncology department in the United States should have IMRT capabilities. And then in the last 10 or 20 years, we started doing image-guided radiation, and that gets us to now, and kind of it'd be interesting to see where things go during our careers.
Do you know what kind of cancer the first patient had that was treated?
I forget. Yeah, it may have been. We could look it up. I could find out for you. There's actually a really good article that I could send you from like 2004 that goes through the whole history of radiation oncology in a lot of detail. And they probably talk about that in there, but it's very interesting. So I have to throw this in. I went to Berkeley, so the first cyclotron, which is now what they use to accelerate protons, was developed at UC Berkeley by Ernst Lawrence. The linear accelerator, though, I have to give Stanford a little nod, was developed or really pushed forward by Henry Kaplan at Stanford. very early on, they were treating malignant and non-malignant conditions. In 1895, they didn't realize that radiating people 20 years later, they would be at risk for second malignancies. Even in 1930, they didn't realize that yet. But some interesting side notes: breast cancer treatment, a lot of treatments were just limited by skin toxicity because the dose that was low energy, so it deposited very superficially. So they would keep giving treatment until the skin broke down to a certain point, and then they'd say, "You're done. You've gotten everything you can get." They treated tinea capitis, they treated tonsillitis, enlarged thymus, ankylosing spondylitis, and it's before NSAIDs and biologic agents for inflammation, so radiation was a very good anti-inflammatory. Although in long-term follow-up, we found there was a high risk of leukemias and second malignancies, so we're not doing that anymore. They treated facial acne just with superficial x-rays. So these are some images I came across from a book about radiosurgery, and I thought these were particularly cool. These are from the 1930s, and these devices are called radium bombs, and these are different arrangements of radium sources. So this is kind of a very primitive radiosurgery. Conceptually, you could call it a radiosurgery device, but the idea was that the radium source pointed at a particular area, and so this is similar to what we do now with an isocenter, but they would have to apply the source very close to the target, and you can see when you look at this is actually a depth, or kind of a dose, photochromic dose curve or dose distribution from this particular radium bomb. You can see that most of the dose was going up here, and then you were lucky if you got enough overlapping where the tumor was. And they had this for head and for intracranial malignancies. I thought this one looked particularly crazy. This is real. This is stuff they were doing back in like the 1930s. So I guess each of these is a source. It's hanging down by these springs. It's hard to imagine this was very pinpoint precise or anything, but the patient's laying here on his stomach, and you're treating presumably a lung tumor, maybe a sarcoma, the scapula. I don't know what they're doing here, but so this is what they were limited to in the 1930s. And then with cobalt, which is a byproduct of nuclear reactions, we got somewhat higher energy treatments, and then with linear accelerators, we're able to get into really high energy mega voltage treatment where you're depositing dose deeper rather than superficially. So a little bit about our specialty about training also. We initially trained as diagnostic radiologists and then would pursue therapeutic radiation after, I should say radiology, after completing a radiology residency. And because of that, our specialty is still under the American Board of Radiology, American College of Radiology, and a lot of people still think we're radiologists. But in the 1970s, they kind of decided this was a very distinct specialty, very different type of clinic structure than diagnostic radiology, and it seemed like the best idea was to split it off into its own training program. So that's, I guess in the late 70s and 80s, most of the big residency programs that are around now formed. But historically, that's why we're kind of under the ABR, ACR. We still have involvement with the Radiologic Society of North America, which is really more, at this point, a diagnostic radiology society, but there's still some overlap. All right, so let's talk about the care path. And again, a lot of this will probably be reviewed since you've already rotated a department, but I think it's good to see it, kind of understand it formally. We'll talk about what makes a good radiation oncology H&P and what steps the patient goes through to get to treatment. So this is the general sequence, right? Consult, then they're going to have a simulation, then they go home, but we go to dosimetry and work on getting the plan together. Then there's QA, or quality assurance, to make sure the plan's going to do what we want it to do, if the machines can actually deliver the treatment. Then the patient gets treatment, and then there's follow-up. So we'll go through each of these steps, and I've kind of put this at the bottom so you can follow along. So at the initial consult, we review the patient's records very closely before meeting the patient, try to develop a preliminary plan, and then we'll do a full history and physical, and an assessment and plan, and decision whether or not to treat. And then if we are going to treat, we do an informed consent. And I would argue that, based on my experience at least, I think we won't do one of the most complete informed consents, kind of in-depth informed consents out of any specialty that I've been exposed to. And I think partially that's because radiation does have a lot of unique side effects that are hard to understand if you aren't familiar with the specialty. And so it's very important that the patients are educated properly and understand that there is potential, for example, for secondary malignancies or late fibrosis or radiation pneumonitis. And so we go through those usually, not to scare the patient. I often tell them it's like buying a car and you get told all the different ways that you could get in an accident. So the chances that it happens are low, but we need to tell you what could happen. So what are the questions that you should ask for every case? I think these are good things to think about just during the rotation as you go through different patients. But should we treat? So do they need radiation or no radiation? How should we treat? Do they need radiation, radiation chemo? Should they have surgery? Should one be before or after the other? For radiation-specific questions, what should we treat? Just the tumor? Do we want tumor and lymph nodes? Do we want the surgical bed? Should there be a margin? And often you can find this either in guidelines or if you pick up a textbook or the blue book or any of the review books. But also looking at a primary article, they'll usually specify, if they use radiation treatment, they'll specify pretty clearly what regions were treated, what dose, what types of expansions they did. What treatment modality? Can you just do conventional like APPA? Do they need 3D conformal where you do a CT and plan it out with more beams? Do we want IMRT? Should they have brachytherapy? Are protons something to consider? Et cetera. What radiation dose? As you've probably seen on your other rotations, there's a whole slew of different doses, and it can be kind of overwhelming. Like, well, why are we doing this for this patient, that for that? Why are we doing one fraction here and 28 here? What's the expected outcome? I think it's also very important before you see the patient, because oftentimes they might not ask directly, but you should at least have an idea. You're talking to somebody where it's a 1-year median survival, or you're talking to somebody where, like early breast cancer, where it's 8, 10, 15 year, it's probably not going to be the cause of death. And then what are the common and uncommon toxicities, both early, so during and right after treatment, and late, so months or years later. Any questions so far?
So, it seems to me oftentimes the patient comes to radiation after having been referred from the oncologist and the surgeon. So the idea of the radiation oncologist choosing whether to treat with chemo and surgery, is that something that really comes into play?
Yeah, well, I think the majority of time, we are generally a referral service. We don't usually get primary patients, but so yes, the majority of times, if they're being referred here, the medical oncologist or surgeon knows that radiation is indicated. But there's definitely times when they get referred as kind of more of a question, like, do you think this would be beneficial? Maybe there were close margins, or and the surgeon doesn't really know the data. They know maybe radiation could be indicated, so they'll send them. And the other thing is, it's good just to make sure, are they getting the appropriate treatment? Maybe the medical oncologist didn't think about surgery, or maybe the surgeon didn't realize that chemotherapy might be indicated because of certain negative prognostic factors. So I think it's our role also to kind of act as a second screen to make sure that they're getting the appropriate treatment. I see that pretty commonly, actually. Not egregious, like total, like malpractice errors, but there's definitely times we'll say, hey, based on this, this, and this, maybe we should think about adding chemo. And the surgeons will go, oh, okay, sounds reasonable. Or hey, this patient had close margins, maybe you should think about taking them back and re-excising the breast. Usually the surgeons will do that, but once in a while they think it's not too close, and we'll say, well, why don't you do this? Or, and then there's certain radiation-specific things. I had a patient once who unfortunately came very late, but had prior radiation. The surgeon didn't realize that, had done multiple operations thinking the patient could get radiation after. And when we saw the patient, we said, we can't do radiation. So the surgeon ended up having to do a much more extensive surgery. So there's definitely radiation-specific indications and contraindications that our referring docs aren't familiar with. So, yeah, good question. Majority of the time, it's pretty relatively clear-cut. But the surgeon just knows they need radiation or they don't. There's a lot of subtleties that we have to decide for each individual patient that the surgeons don't. All they know is they came down and they're going to get radiation. So what makes a good radiation oncology H&P? I think one thing radiation oncology in general prides itself on is we have a very full and extensive history in physical. If you talk to the other residents around the hospital, they'll often say they love it when somebody's been seen by us because we have a very clear, well laid out, detailed H&P that they can then just copy. But it's also important for us, that we often get them after they've been through a long series of different treatment regimens or different things, and so it's good to lay it out very clearly. What have all the staging studies been up till now? And then another thing that we look at is what's our patient's other medical problem, what are their medical comorbidities and their performance status. If they have early breast cancer and diabetes, we should treat their early breast cancer, but we should also make sure they're plugged in with their primary care, because it's probably going to be the diabetes that causes more morbidity and more potential mortality in the future. If they have intermediate risk prostate cancer and heart disease, there's debates about whether they should get androgen deprivation or not. There could be some increased cardiac risk. If they have glioblastoma and don't have good social support, are they going to be able to get in for their treatments? Are they going to have somebody at home who's able to help them if they start deteriorating further? And then bone metastases, they have extensive systemic disease. So it's easy to say, oh, they're having pain, let's treat it. But if they have extensive disease and poor performance status, then maybe we should just do a single fraction, send them home, plug them in with hospice. If it's their only side of disease, maybe we can do SBRT and treat it more aggressively. If they're somewhere in the middle, maybe we'll do 10 fractions. And there's data to kind of argue for any of those. So for an H&P, you want a full history, good HPI, should be in full and detailed in chronological order. You want presenting symptoms, any workup, staging studies, pertinent labs. In the past medical history, you always want to ask, and I can give you my template that I use, and you can use it during the rotation to you can fill it in for each patient that you work up, but you should always have prior radiation treatment. If they have had radiation, you want specifics, what dose, where was it to, and who gave it, and what were the dates, if we can get it. Prior chemotherapy, when was their last cycle of chemo if you're going to treat a bone met. If it was yesterday, you might want to hold off a few days so they don't get toxicity. But any prior chemotherapy you should also have. So I always have a heading after past surgical history. Then I have prior radiation treatment, prior chemotherapy, and connective tissue disease, which is considered a contraindication like scleroderma. So I always ask my patients, and I have yet to have anybody say yes, but it's good to just ask, because the one time somebody's like, oh yeah, somebody did tell me I have scleroderma, or okay, maybe we shouldn't be radiating, Crohn's disease, stuff like that. Family history, I always want a full family cancer history. I think it gets less important when you start getting into like an 85-year-old smoker with lung cancer. But even there, it's good to ask. But obviously, if you have a 35-year-old woman with breast cancer, you want a good detailed family history. Any gynecologic history, so especially for breast, endometrial, cervical cancer, you want a good gyn history. And then social history, so do they have family? Do they have plans for future children? Obviously, postmenopausal woman, that's not an issue, but any man you're treating anywhere near the pelvis, probably a good question just to ask, because there's an attending here, he treats at a satellite facility, he's been an attending for about 30 years. And I remember he had this story, he said he had a patient, this 80-something-year-old guy who had heterotopic ossification, had surgery, came down for prophylactic treatment, and afterwards somebody mentioned that he might have a lowered sperm count. He flipped his lid. It's like, how do you know I didn't want to have kids? And apparently he had a younger wife. So you never know. It's something to think about. If it's a younger woman, maybe you might want to check a beta HCG. Are they employed? Are they going to be able to work during treatment? What's their job? What do they do? How is this going to affect their ability to work? What's their living situation? Where do they live? I always ask where somebody lives and how long it takes them to get to the hospital, because we're talking about 5, 6 for prostate cancer, 8 weeks of treatment every day. Are they going to be able to drive back and forth? What's their support structure? And then obviously smoking, alcohol, and illicit substances. For physical exam, you want to do a good, complete physical exam. More extensive exam on pertinent anatomical regions. So if it's breast cancer, obviously breast and axillary nodes. Prostate cancer, you can do a GU exam, rectal exam, although sometimes I've noticed the attendings now will just defer that because they feel like it doesn't really change management. But GBM, you want to do a good neurologic exam. And bone met, you want to do a good musculoskeletal exam. You'd be surprised sometimes we find other sites of painful disease, and we end up treating another spot that the referring physician was kind of focused on the really painful site, and they I wouldn't say miss, but they just said, oh, go to radiation, and we'll say, well, you're having pain here also, let's treat that. And then I always, after my physical exam, put a performance status. So what's their KPS and their ECOG or ZU score? I think everybody calls it ECOG, but you might see ZU-RA, it's the same thing. ECOG is Eastern Cooperative Oncology Group, but I put both because you never know when somebody goes back to do a chart review which one they might want. I would say ECOG is easier to understand. 0 is completely asymptomatic. 1 is some symptoms but otherwise functional. 2 is out of bed more than 50% of the day but symptomatic. 3 is in bed greater than 50% of the day. 4 is bedbound, severely ill, and 5 is dead. KPS is more of a scale from 100 down to 0. And I bolded 70 and 2 because I find those are a good cutoff. 70 is able to care for yourself but not capable of normal activity. But generally 70 or above is decent functional status. Same thing for ECOG, 2 or below. Probably able to care for themselves, make their own meals, get around on their own, but maybe not able to work. And you'll see a lot of randomized trials will limit patients to have to be KPS 70 or greater. Usually now I find it's more ECOG, 0 to 2. But it's always good to put that in at the time of the consult because you're meeting the patient, you're seeing them, you're really familiar with all their kind of ins and outs. And I've had personal experience. You go back and you start reading a note, and you're like, I don't know, this guy could be an ECOG 1, he could be an ECOG 3, I don't know. And then in the assessment, you always want to stage the patient. So early breast would be like P, T1B, N0, M0, stage 1A. So, there's the TNM staging system. Each site has a different TNM system. Megan, you know what the P stands for?
No, I was going to ask.
So P is pathologic, so it means they've had surgery and it was examined by a pathologist. So the measurement for the T stage is based on pathologic measurements. And the nodes were dissected. So P, T1B, N0. What do you think C stands for then? Clinical. So that's based more on clinical exam. Sometimes you can use imaging, usually not. Whereas a P, T2B would tell you that they had a prostatectomy. Hang on one sec. All right. So like I said, there's different staging though for different tumor sites. GBM or astrocytomas in general actually don't have TNM. Most CNS, really all CNS diseases don't have TNM. It's based more on grade. So GBM by itself is defined as grade 4, but if you said they had a grade 4 astrocytoma, that means GBM. And talk to the residents when you're doing the rotation. And we all have staging manuals kind of around the resident room, and any of your handbooks should have staging at the start of each chapter. Even for bone metastasis, if they have only one side of bone metastasis, you could say it's clinical T3, N3, M1, which tells you also about the localized disease. If they have this disseminated metastatic disease, then we usually don't start trying to stage the primary tumor. You just say stage 4 or metastatic. And then lastly, you want to plan. So formulate a preliminary treatment plan for each patient. I always try to do this before I meet the patient, even though things may change if it's not totally clear cut. But it's good to have a preliminary plan kind of in mind before you go in to meet them. And then what are the radiation treatment options? External beam radiation, like the linear accelerator, we call it the LINAC, is kind of the workhorse of radiation oncology. So most patients are getting external beam radiation. But there's different modalities. So photons are what most people get. Within photons, you have different energies usually. So here we have 6, 15, and 18. I think one of the machines may have a 10 MV option. But usually, most LINACs will be commissioned, meaning they're kind of certified to treat with a low energy, like 6 MV, and a high energy, like 15 or 18 MV. And between those two energies, that's enough to develop any treatment plan you want. We also use electrons, and we'll talk more on... electrons. So electrons, you actually can just increase the energy of the electron beam the machine's generating and generate a lot of different energies. So usually here we have 6, 9, 12, and 16 MEV electrons, and they're more useful for superficial treatments. Within photon treatments, we have 3D conformal, IMRT, IGRT, VMAT. It's kind of an alphabet soup, and you'll see, but as you go through, you'll start to pick up what some of these are. 3D CRT is 3D conformal radiation. Essentially, that means that the patient had a CT simulation and a computer was used to plan out the treatment to see how conformal the dose was. but all the beams, all the fields are defined by the physician and dosimetrist. The computer doesn't actually shape the fields for you. IMRT is kind of more advanced. The computer optimizes all the fields. So you define the number of fields. So here's a question, John. Does the computer or do you define the angle of the fields, like what angle they come in from?
The computer defines that.
So actually we define the angle of the beams, and we define the number of the beams. We actually even tell the computer, so each beam has a segment, or has a number of segments. So within each beam you have a bunch of different configurations of those MLCs, the micro-leaf collimators, multi-leaf collimators, sorry. So we actually tell it the angle of the beams, the number of beams, and we tell it the total number of segments that it can use across all beams. And then the computer decides beam 1 should have 8 segments, beam 2 should have 6 segments, beam 3 should have 12. And it optimizes what shape each of those segments has. But it's not quite as easy as just saying, like, here's a prostate, computer, come up with the best treatment for me. So we actually have, like, for prostate or head and neck, we have pretty standard beam angles that we use, numbers of segments that we use, and then we let the computer optimize that. Tomotherapy is I think I have an image of it coming up, but it's essentially a linear accelerator mounted on a CT gantry, and it spins around the patient. And then CyberKnife is a linear accelerator. It's the CyberKnife mounted on one of those robotic arms they use for building cars. But when you hear CyberKnife, tomotherapy, those are all still photon linear accelerator based treatments. And so this is a linear accelerator mounted on the arm. Megan or John, do you guys know what these are here?
Is that for tracking?
Yeah, so I think Varian calls it exact track. I forget what CyberKnife, so maybe it's the CyberKnife name, but this is a KV imaging source, so diagnostic imaging source, and you have the film in the floor, and so they're at 90 degrees to each other. And so during treatment, you can image the patient kind of real time and see what a fiducial is doing, or what the tumor is doing, or the bony anatomy is doing, and the computer can track that and shut off treatment or make adjustments based on the movement. So we have that on our first linear accelerator downstairs. They installed it, but I don't think we just got that. It's new within the last year, and I don't think they've commissioned it yet. I mean, they haven't kind of verified it works properly and everything. This is tomotherapy, so you have a linear accelerator mounted in a CT gantry, and it spins around the patient. You saw VMAT in my alphabet soup on the prior slide. That stands for volumetric modulated arc therapy. That's the linear accelerator company's answer, or the kind of classical linear accelerator answer to something like tomotherapy. So what that is IMRT, you have specific angles that the machine rotates to and then shoots a bunch of segments. With VMAT, volumetric modulated arc therapy, the LINAC head is rotating while the beam's on, and it'll do 360 degrees or sometimes 720 degrees of revolutions before it shuts off, and the whole time the beam's going and the leads are moving. So it ends up having a similar, works similar to tomotherapy.
Do you guys have one of these?
We don't have tomotherapy. No, our philosophy here is if we can treat it with a linear accelerator, why do we need to get something else that isn't as versatile? Linear accelerator, you can treat a palliative bone met just as easily as you can. There are certain situations, kind of specific situations, where CyberKnife or tomotherapy or some of these more specialized gamma knife where they're advantageous, but I think for the most part we feel like we can accomplish almost everything with a linear accelerator. So why invest the capital into something that's more specialized? That's the philosophy here. We're, I think, kind of on the far end of the spectrum. If you go to some other institutions, you'll find that they fall on the other end, and a lot of places in the middle, they might have one or two kind of specialized devices. This is a gamma knife here. So this is not linear accelerator based. So radiosurgery, sorry, just to back up a second, is treating a one big fraction to a very localized, precise volume. And you can do that with gamma knife, which is not linear accelerator. It's I think the new gamma knife now has 192 cobalt sources that are all kind of aiming at the central location. The head, it's really just for treating head intracranial lesions, although they're starting to do some like base of skull, head and neck stuff, but it still really primarily treats intracranial lesions. CyberKnife, which is a linear accelerator, and LINAC-based SRS can also be done, but these all, for stereotactic radiosurgery, they all have the head frame. I'm sure you saw this at Pitt. I don't know if you saw this here. So I'm sure we'll have an SRS case while you're here. You should definitely see this, and you'll definitely see some of the other places you're going, I'm sure. But you attach a head frame onto the patient, and they're immobilized by the head frame onto the treatment table, so your accuracy is down to within a millimeter or so you can give these very high doses to a precise volume. So this is a gamma knife. This is what the inside of the machine looks like. The patient's laying on the table, their head's attached up here, and it slides into this. It used to be a helmet. This is the new gamma knife. I can explain in more detail how these work. It's kind of cool how the technology now, they actually, too much for this talk, but ask me later, I'll explain how the gamma knife works. And then you have particle therapy, protons. I'm sure you've heard about this. The advantage of protons is they give you this Bragg peak. We'll talk about this more in the next lecture, but I'll compare this on the next slide to photon. This is called a depth dose curve. You'll see these more. You have the depth in tissue or water versus the percent dose. So protons come in, they deposit a little bit of dose along the way, then they have this big dose deposit, and then they fall off completely. There's nothing after the Bragg peak, right? That's the advantage. It gives a potential dosimetric advantage over photons. The disadvantage is they're more expensive, and you can have some neutron production. There's some other disadvantages. I won't get into those, but it's kind of an ongoing argument in the field about how beneficial protons really are. There's definitely situations like pediatrics, certain skull-based tumors where they are advantageous, but for treating prostates or certain other malignancies, it's debatable. And then neutrons and heavy ions are also used to treat patients, although neutrons are really fallen out of favor. I think they're more popular in like the 80s, and there were some trials run, and the toxicity was higher, and I don't think anybody really is using those much anymore. And heavy ions, there's only, I think, 3 centers in the world that do this. I think it's 2 in Japan and 1 in Europe, maybe the other way around. Nobody in the United States uses them for clinical treatments at this point, but that's like carbon, iron. They have the same idea as protons with this Bragg peak, but it's actually even a sharper Bragg peak.
Is that also just as expensive, I would think?
Or more expensive, because they're heavier, so they take a better synchrotron to accelerate them up to the energies you need to treat malignancies. So this is a depth dose curve for different energy photon beams. So here's 25 MV, very high energy, 10 MV, kind of intermediate energy. The orange is 4 MV, that's about equivalent to a cobalt source. So cobalt was what they were using before linear accelerators. And you can see you get this dose, the maximum dose falls within the first 5 centimeters. You can see as the energy of the beam goes up, your max, we call this Dmax, gets deeper. So this is why we talk about a skin sparing effect with high energy photons, is that the Dmax gets deeper with high energy. But you can see then you get this tail, and when we're treating a tumor that's say 15 centimeters deep, your maximum dose is actually happening pretty shallow. And then you get this fall off. So we take advantage of using a bunch of different beams to kind of add up the dose in the middle, but you still get this Dmax out here. Whereas with protons, what they do is they take a bunch of different energy proton beams, so they overlap the Bragg peak, and you create a beam that looks like this. And this is called a spread out Bragg peak. But after the dose is deposited, you get no tail. So here you get, if you line up, say 7 beams for IMRT, each of those beams is going to have exit dose, kind of that tail coming out the other end. But with protons, you don't get that at all. So that's the advantage. So if you're treating, say, a skull-based tumor, you can have an area where the protons overlap, but then nothing goes into the spinal cord. Or say you're retreating a tumor, or very little goes into the spinal cord. In pediatrics, you're treating craniospinal radiation, where you have a beam coming in, a PA beam from the back, you're not going to have any dose coming out through the heart and the lungs, whereas with photons, you're going to have dose coming out through the heart and the lungs. So that's kind of the theoretical advantage. There's also brachytherapy. We talk about low dose rate, high dose rate. So less than 2 gray per hour is considered low dose rate. High rate's greater than 12 gray per hour. And pulse dose rate, which is really, as far as I know, only done at MD Anderson, but it falls somewhere in between, and it's kind of a hybrid of the two. They use a high dose rate. This is my understanding of it. I've never actually seen it, but they use a high dose rate source with the patient in a bed, but they basically load it for a short period of time, take it out, and then load it for a short period of time, take it out. But in between those applications, the nurses can come in. There's no exposure to that personnel, and then there's some theoretical, advantages of having the lower dose rate. Anyway. Just so you've heard of it. We talk about activity of sources. So 1 Curie, which Madame Curie defined as the amount of activity, so how many photons were released by, I think it was a gram of radium in 1 second, is equivalent. So 1 photon, 1 gamma ray being released is called a becquerel, 1 decay. So it's 3.7 times 10 to the 10th becquerels is 1 Curie. So that's 37 billion becquerels per Curie, and an HDR source is about 10 Curie when we get it new, and then it decays. I think the half-life is about 60 days, if I remember right, so about every 3 months we replace it. No, do we replace it every 60 days? I gotta look that up now, but we get it, it's about 10 Curie. It's an iridium 192 source, so it's releasing about 370 billion photons per second. So very high activity, whereas low dose rate or much lower, we're talking about in millicurie dose levels. Still a lot of photons, but this is an example of brachytherapy for prostate where we do the seed implants. Stan Liao may have some cases this week here or this month here, but you put in a bunch of sources. This is actually an HDR implant here, so they'll put catheters into the prostate. And rather than loading iodine seeds, they then take the patient down, hook up a bunch of catheters to an HDR afterloader called a robot, but it's essentially a very small iridium source, high activity on the end of a wire. And the robot will load it into each catheter to specified depth, retract it slowly over it's been calculated out by the computer how long it should dwell at each point. We call it dwell times. So how long does it dwell at each spot, and you deposit the dose that way. Low dose rate prostate implants with the iodine seed. This is a low dose rate brachytherapy implant for cervical cancer. So this is a lateral film. I need to get some better images of these. I can show you what they look like, but it's called a tandem in ovoids. This is the tandem coming up into the uterine fundus, and then these are ovoids. So we're looking from the side. So on end, they look kind of like a cylinder, but we're looking from the side. And you'll load 3 sources into the tandem, and then a source into each ovoid. There's 1 in each lateral fornix. I don't know if either of you have seen these. This is a Foley bulb, so this is where the bladder is, and there's also a rectal tube, which I can't see on this. And then they're measuring the distance from the sacrum to the sacral promontory to the tandem. And they used to do this all just with AP and lateral films, and they would calculate out how much to deposit, how many milligram radium equivalents to put in. And now we're doing this with HDR also. And we'll take CTs or even MRIs and plan it out using 3D volumes. This is breast brachytherapy, so they can do needles. One of the attendings trained somewhere they do a lot of this, and she said they called it breast kebab. But you can do brachytherapy like this. You can also do balloon implants with mammocytes, mammocyte balloon or other balloon implants, where you put it into the lumpectomy cavity and load a source with an HDR afterloader into the balloon. And then what we do here is actually external beam partial breast irradiation, where we plan it out with a linear accelerator, and there's no actual implant into the breast. But this is what you call interstitial. There's also intracavitary, which would be like this. So like prostate implants are interstitial. Cervical implants are usually intracavitary, or you can actually do interstitial and intracavitary. So. All right, and then they get a CT simulation once you've decided they need treatment. And the physician determines how they're immobilized, what CT region we want to scan, what slice thickness we want. Do they need contrast? Do they need rectal contrast, IV contrast, PO contrast, bladder contrast? That's up to us. And do we want to get respiratory gating? So we track their respiratory motion. So if we don't tell the therapists who run the simulator what region we want to scan, and we say, oh, well, we wanted you to scan all the way up to the base of skull so we could see the neck on a lung plant or something. It's not their fault. We define that. Patients set up then, scanned and marked with a small tattoo by the therapist, and then the physician will place an isocenter, which is the point that the linear accelerator rotates around. So the gantry of the linear accelerator rotates around this point, the table rotates around the point, and the collimator, the head of the accelerator, rotates around this point. So we'll mark that when the patient gets simulated, and then the therapist will mark the external kind of points on the patient that correlate with that. So when you're downstairs and you see a simulation, you should go in and ask the therapist, it's all very nice, go in and say, can I kind of watch what you guys are doing? They'll explain everything. And brachytherapy, radiosurgery, these all require simulations. They may be specialized, like brachytherapy, we do an ultrasound planning session. SRS, they do it with the frame on. But almost all radiation treatments get some sort of simulation. Even when we do a palliative whole brain treatment, we take a measurement of the head. We kind of consider that a pseudo simulation. We figure out how wide the head is, and we simulate based on the thickness of the head how much radiation we need. So this is an example of a simulation order sheet. This is a breast order sheet, so you can see orientation is supine. You could do prone. Arms could be up at the side. You could have one up, one down. What position the head's in? Is it turned? Is it extended? Do you want bolus placed at the time of simulation? What kind of devices are you going to use? We'll talk about these more in the third lecture. Free breathing or gating. What side of the field of the body is it on? Sorry. We also usually tell them what type of treatment we're planning so that they have an idea of what position. There's different subtleties in the setup. And then they always want to know is the consent signed, etc. Once you get the simulation, it goes to dosimetry, and we do any image fusion of like PET scans, MRIs, any other scans that we want to use. And then the resident usually will delineate the target, so it will contour out where we want to treat. And you should definitely have an opportunity to do this with the residents. A lot of times you may end up observing them, but if you're with me, I'll definitely try to get you using the mouse. This is one of our residents last year. This is the planning station, but she's doing a breast plan. She also has a breast atlas. There's a lot of atlases for every site: prostate, breast, head and neck, that the RTOG puts out. There's a lot of other ones available. So we'll use those to help us kind of define our volumes. And then she has a chart here. We're going to paperless charts, but always good to look at the pathology, look at any diagnostic scans, figure out what areas you want to cover. And then you select the modality and beam. So do you want to do a clinical setup? This actually, you don't do any planning like this. You just take a measurement, like I was saying, put them on the table, do kind of a hand calculations. This would be like an emergency treatment. 3D conformal, we'll do an IMRT. Do you want to do stereotactic body radiation, radiosurgery, etc.? Any questions so far? No? So this is a kind of very important fundamental concept to understand. The GTV, CTV, PTV, and you've probably heard about this already. But this is kind of how we define our targets. First thing we do is, so say for a lung tumor, we'll contour a GTV. That's just what we can see that's involved. So at nodes and primary tumor that we know, based on imaging, looks like cancer. We then expand that to include a CTV that might be either areas at risk for microscopic local extension or microscopic involvement of lymph nodes. So say the whole nodal station surrounding an involved lymph node. So here's our tumor. So our GTV is really just what we can see. Right? Our CTV is then an expansion on that to include microscopic disease. The last expansion then is PTV. It's the planning target volume. And this is to account for patient setup and just different setup day-to-day, table sag, things that we can't really account for clinically. And usually that's a standard expansion. Megan, say I was contouring a prostate and, well, let's say I'm doing head and neck, and I contour the nodal levels for a CTV. So I contour the vessels and then I expand them 7 millimeters and they expand into the sternocleidomastoid. Would I, for a CTV, would I want to include the sternocleidomastoid, or would I want to shave it out of the sternocleidomastoid? Shave it out. There's actually an exception. You're right. But there's an exception. Say they have extracapsular extension or it looks like it's invading, then you might include it because it could be invading. But if it's just a CTV, no actually involved nodes there, then yeah, you shave it out because there's no reason the muscle is not going to have microscopic disease, right? Now say I do a 5 millimeter PTV expansion. John, I do the 5 millimeter expansion. Would I want to shave that out of the sternocleidomastoid?
We want to keep that.
Yeah, you keep that because that's to account for the whole body shifting day to day. You will see sometimes that people will cheat with a PTV because it's really close to your critical structure, and so we don't want the dose to go over that far. But then we're really cheating on how well we're going to cover it day to day.
So is it being each zone being dosed differently?
No, so we usually prescribe them to the PTV. Now you can have different PTVs. So you can have a PTV1, PTV2, PTV3. That for like head and neck, we usually have a low, intermediate, and a high risk volume. And each of those PTVs will get a different dose prescription. Usually here we do a very unique head and neck treatment, but it's 39, 54, and 75 gray. But within that PTV, you have a CTV, and you may or may not have a GTV. So our low risk PTV actually does not have GTV. It just has a clinical target volume that we say is at low risk for microscopic disease. Same thing with the intermediate risk volume, but those are then adjacent to where we have gross disease. But then the gross disease will get the full 75 gray, and that actually has GTV in it. Does that make sense?
Do you guys ever replan in the middle of treatment if you think that the...
We do. So we'll often scan like lung patients or head and neck patients partway through treatment to see if things have shrunk. Can we shrink down our PTV? Head and neck, people lose weight, and so we may just have to adjust our plan purely because their contours have changed, and so the dose is going to be different. You know, if they get thinner, the total dose that goes to them is actually going to get hotter. So if they lose a significant amount of weight. So Dr. Haraf, our head and neck clinic, basically scans everybody midway through treatment, transfers over all their volumes onto their new scan and sees how it correlates. And if they've changed significantly, he'll replan it for their final boost. Good question. There's also something called an ITV you might hear about, and that accounts for, it's called the internal target volume. That accounts for motion of the tumor. So if we get a respiratory gating scan or a 4D CT scan, we can see how much the tumor moves, and then we can account for that in the ITV, which would then be expanded to a CTV. So you would go GTV to an ITV to a CTV to PTV. Don't feel like you have to understand it all right now, but to at least see what the terms are and kind of get some idea in your head. This is an example of an atlas that we use for contouring. So this is a breast atlas for the nodes. So you can see supraclav, axilla level 1, 2, 3, internal mammary. And so they give borders for basically all the dimensions: cranial, caudal, anterior, posterior, lateral, medial. And initially, when you're a first-year resident, you look at this and you go back and forth. You know, and then this is what the atlas actually, they give you an atlas too, and so you can correlate the table I just showed you to this actual atlas. So here you can see axilla level 1, and it's bounded by the pec anteriorly, lat posteriorly. You kind of come out into the soft tissue anteriorly, I should say laterally. Medially is chest wall, not including the ribs. Here's internal mammary, you just contour the vessels. So they define that for you. Here's the chest wall volume. And as you go through your training, you get better and you kind of start to just remember it, and you just maybe refer back to it for reference. But we have these for breast, prostate, head and neck, GI, a lot of the GI malignancies, lung, they'll give you nodal stations. So it's not like you're just hanging out there blind trying to figure out what to contour. And then we write a prescription. So we define the dose, the energy of the beams, although usually the dosimetrists figure out what energy works best, but we then write the prescription for what energy to use. What's the fractionation schedule? Is it 1 treatment, 5 treatments, 28 treatments? What type of imaging are we going to use for image-guided radiation? And are we going to use bolus or other types of modifiers? So this is a handwritten prescription card. Pretty soon we're going to move to electronic prescription cards, but it'll be the same information. So I kind of blew it up so you can see the important stuff, but we have the diagnosis up here, and then you can see how many fields, what site are we treating. The energy is 6x. This means 6 MV, so it's photons, not electrons. What's the technique? Are they prone or supine? So this is kind of a special daily, once a day, Monday through Friday, 1.8 gray to 50.4 gray total. And then we have a boost that's also using, this is actually using electrons. It's funny, I think that should say EV. It's on phos, meaning it's just pointing right at the lumpectomy cavity. They're now on their back, 5 fractions a week, 2 gray a day, and then you have your total dose, 60.4 gray.
This might be a basic question, but the different energies of photons, is that just different in terms of the depth distribution that you showed before, or are there other sorts of...
No, it's really just different based on that depth dose curve. There are a few differences. There's some subtle differences in how they might interact with the tissue, and we'll talk about that on Thursday more, but there's Compton interactions, which are what we want to have happen to create electrons that create free radicals. If you go to high energies, you start getting into something called pair production. The chance of that happening even at like an 18 MV photon beam is low because, so we'll again go into this more Thursday, but when you say an 18 MV beam, it's actually an electron beam of 18 MeV that hits your target, and you get photons that go from 0 or like virtually no energy all the way up to 18 MeV. So 18 MV has an average energy of only about 6 MeV. If that makes sense. So the photon beam, when you say MV, is actually, it's the maximum energy. It's not the specific energy of the beam. Whereas with electrons, when we say I'm treating with a 12 MeV electron beam, it's actually the specific, the electrons, all the electrons that come out of the machine have that energy level. And as they hit the patient, they then decelerate. Whereas with photons, you get a spread out dose distribution, energy distribution of the photons. Because as the electrons create the photons, they can create higher energy or lower energy photons, just random chance. So even at an average of 6 MeV, the chance of this pair production is low, but it goes up with energy. We'll talk about it more next lecture. So essentially, it's just that depth dose curve. So there's a disadvantages. When you treat a breast cancer patient, if you just use high energy beams, you give too much sparing and you miss some of the superficial breast tissue. But if you treat with just low energy beams, you may actually have too much of a hot spot near the surface, so it will mix them. In this patient, she must have been thin enough that we could just use the low energy beams. We then do a plan evaluation. We look at a dose volume histogram, target coverage, critical structures. So this is a planning worksheet that we use here. So you can see different parameters. So the V100 is the volume receiving 100% of the dose. We want, for our PTV, we want it to get greater than 95%. We also, this is a prostate clearance, sorry, I should have specified. The rectum, we have a V70, we want this to be low. So we're saying the volume getting 70 gray should be less than 10% of the rectum. But we usually give them a few different parameters to try to meet. You could have a V70 less than 10, but a V60 of 80% conceivably. That doesn't happen usually, but we want to make sure that it's not just, we look at multiple points. Bladder also has some dose constraints. So this is how we evaluate plan. We'll look at the isodose lines. So if you guys have ever gone backpacking or hiking, you get a topographic map. That's what isodose lines are. Same idea. Each line represents a dose level, and as you go in, you're getting to higher dose. So here's 78 gray is our prescription. So you just actually see these little spots of 78 gray, but 95% or so, the 7644, is covering everything, right? When we looked at those planning constraints, that was what we wanted, was 95% to cover everything. But then you can look at low dose. Here's our 50% isodose line, you can see it spreads out a lot farther. You get some spots out here. So that's what we're looking at when we evaluate these. Here's a breast plan, so you have tangents, a beam coming in from laterally and a beam coming in from medially. Same thing, you have your prescription dose in the red, covers all the breast, looks good. You have some hotter dose up here. You know, that's kind of expected because the breast is thinner up there than down here, so it attenuates less beam, so you get more dose. And then this is a dose volume histogram. So you have total dose here and percent volume of the structure. So 100% and the dose. So if we look at our coverage of our GTV, the red, you can see 100% of the GTV. This is actually the lumpectomy cavities, the red, is getting 50 gray. Megan, the left lung is yellow. So what would the V20, so the volume getting 20%, 20 gray, be of the left lung? So the yellow line is the left lung.
Yeah.
So what's the V20 of the left lung? What volume of the left lung, what percent volume is getting 20 gray? Right here, 20.
Yeah, it's not 0.1, right?
Yeah, 0.8, 0.1. Yeah, exactly. So about 8% maybe. John, what's the V40 of the heart? So the volume getting 40 gray of the heart.
It looks like about 3%.
Yeah, so it's really low. So that's really good. That's normal for lung treatment. You can see a little bit of the heart's getting skimmed here. The lung gets a little bit of dose, but that's very acceptable. The kind of stuff that we look at is how's the coverage of our target, and then how's the sparing of the rest of the normal structures. So, Megan, what would the V50 be of our target volume here, approximately?
For the PTV,
Yeah.
we're way up at like 90.
Yeah, 90, 95%. So pretty good, right? John, what would the V10 be of the right lung? Actually, the left lung. So
The left lung is
0,
0.
yeah. You can see, right, if we look here, there's no dose coming over in the lung. So this is a prone patient. So we treat lower risk breast patients prone, and you can see the breast hanging away. So that's why we'll do this. Now, if we're trying to treat the chest wall, we don't do this because this actually spares the chest wall. If we treat the chest wall prone, the heart falls into the field. So we just do this for early stage, really. There's a few situations. And it also spares toxicity because you don't get skin folds. So these really large-breasted women, if you treat them supine, the breast falls out laterally, you get a skin fold, they get really bad skin toxicity there.
There's a CT scan prone, I guess.
Yeah, I know, it's unusual. So here's that prostate plan again. Here you can see all the different dose constraints, DVH volumes. So, Megan, what's the V70 of our rectum? Which is kind of hard to see. It's the brown.
That's 1, middle over.
Well, percent. So
Sorry,
12%. Yeah, that's acceptable. I think they said they wanted less than 10, but really you try to keep it less than 20. Those are kind of more tight constraints. John, what's the V60 of the bladder?
Bladder is the last here.
Oh, that's okay. It's this kind of yellow greenish thing.
The V what?
60?
V60 is like 25%.
Yeah. Now, all right, we have two different. You have PTV1 and PTV2. Any idea why we have two PTVs for prostate treatment?
Or when the changes in like the bladder or the rectum being into your fold, you count for movement?
No, not exactly. So what structure adjacent? So we usually try to treat them. I know you're thinking of. We usually try to have the patient either empty bladder or full bladder for every treatment. But this is a bigger volume. So what structure do we worry about? What adjacent structure to the prostate is like one of the first places the cancer invades?
Seminal
Yeah, the seminal vesicles. So when we're treating intermediate risk prostate, we usually treat the seminal vesicles and the prostate to 50 gray, and then we'll boost just the prostate to 78 gray. Unless there's risk for seminal vesicle invasion, then we may go higher for the seminal vesicles. So this first PTV is going to, looks like about 50, 54 gray. And then it starts to fall off because it includes a certain percent is in the PTV too. But then the second PTV goes all the way up to 78 gray. So that's what's going on here. That's why this one starts to fall off. So it's getting the full dose to the seminal vesicles up to probably 54 gray, it looks like. And then it falls off, but then all of PTV2 is included by that first PTV. We just shrink it down a little bit. Here's a DVH for a brachytherapy implant. So this is our prostate. You also have a rectal DVH and then a urethral DVH down here. And you can see same thing. You have isodose lines. So the green is our prescription dose, 145 gray. The yellow is the 130% isodose line. And then we look at the volume of the rectum getting the prescription dose, usually like D1 cc. So what dose is going to, or 2 cc is very, very low. You usually want about 70% of your prescription. The urethra is getting almost no dose, and then you can see you get this very high dose region. That's because the C's are actually in the prostate. Here's a glioblastoma. So you can see we have optic nerve, brainstem. So Megan, what's the V? So the brainstem you try to keep below 54 gray. What's the V54 of the brainstem? It's that darker purple, this one.
54, like 20%.
That's about,
over there. Okay.
yeah.
So like 10%.
Yeah, about 10%, but you can see it drops off very quick. And so you actually, sometimes we'll go up to a point dose of even close to 60. What about the optic chiasm? We try to keep below 55 or 54. You can see it hits right here, so that's acceptable. The optic nerve, same thing, hits right here. That's acceptable. And then we have our same thing. We have two PTVs. So we have an initial PTV. You can see it shaded here. It's going to 46 gray. That's that blue line. And then we have a high dose that's going to 60 gray. This is a palliative treatment. So we're treating a iliac and kind of pelvic mets. You can see the fracture right here. So APPA, but you can still get isodose lines. You can contour in a GTV and make sure you're covering it. And then these are called, so this is a block, and we actually, so the attending and the resident drew these in to find where they wanted to treat, and then we hand it off to dosimetry and they do all the calculations for us. And then we do quality assurance, so we're almost done. I think just a few more slides. So before the patients get treated, we make sure that the treatment is actually going to work like it's supposed to. And for IMRT, it's particularly important. So you have all those different segments. You might have 90 segments that are going to get treated. And the computer thinks, oh, this looks great if I do it like this. But the machine may not actually be able to get the leaves into certain positions, or the gantry can't go to a particular angle. So this is called a map check, and it's a diode array. So there's tons of little diodes in here that can sense radiation dose. And the night before the patient starts, or even a few days before, after all the patients are off the table, the physicists go in and will run an entire treatment plan on these diode arrays, and you get an output of what should be, what you should see, and what the computer thinks it's going to do, and what actually happened. And it'll match up. So this is an example. It's kind of a cross section. These points are where the diode array actually measured the dose, and the graph is what it should do. And so you can see it falls right on it. So that's perfect. So this would be acceptable. But once in a while we catch one where one of these points is off. Either it's the distance of a dose is outside of where you think it should be, or the percent dose is, say, 5% hotter or colder than you think it should be. This is called a fluence pattern. So this is what IMRT does is you get a fluence pattern. So the darker it is, the more dose you're getting to that area. And so by creating all these different little segments, you can create a kind of unique fluence pattern, and then you overlap all your beams, and you end up having that very conformal radiation treatment. But because of that, you want to make sure that the pattern is actually what you think it's going to be. So that's what they check with these QA checks. And this is kind of stuff that, even as a resident, we don't really get exposed to. So it's good to know that that goes on.
Is it every day?
Most evenings, the physicists are in there checking some plans and getting them ready to make sure that they can start.
They only do it once per new plan.
Yeah, once per plan. Yeah. Once they verify that it can do it, that's fine. But they check every field. Now they don't have to move the gantry around. They just have the gantry straight up and down. They put the diode array on the table. But then they run through every single field and every segment and measure this for each field and make sure that it falls within tolerance. And as long as, usually they say, I think plus or minus 3% and 3 millimeters is kind of the rule of thumb. And they have these ways of kind of calculating, but as long as it's within tolerance, then they'll say it's good to go. But if they get one that's way out, usually that doesn't happen. I mean, the computer knows what should be feasible, but once in a while, they don't quite get along. And then, the patient treatment course, the therapists give the treatments, we don't. Port films are once weekly. Nowadays, we're doing KB imaging and getting daily imaging very frequently, but kind of the traditional treatment was on Mondays. They would check a port film, make sure that the patient was lining up correctly. The attending would check, make sure, see if there were any shifts that needed to be made. Tell the therapist, you need to move them anterior, posterior, lateral, half centimeter. They'd recheck the port film. Once they agreed it looked good, they'd treat them all week, and then the next week they'd check again. Now we're doing onboard imaging where we check. The therapist actually will line up the patient each day, and then the attendings just check in the evening to make sure that things look okay. We also see patients once a week while they're on treatment, for on-treatment visits, check in, see how things are going. And then we usually do an end-treatment visit. The nurses always see them, give them instructions. Sometimes we'll see the patient if they had a lot of trouble. We might check in on their last day to kind of say goodbye. And in each patient visit, we'll review total dose, interview and examine them, look for signs of toxicity, and review any labs, make sure they're getting their chemo appropriately. So just a little snippet about why we do image-guided radiation. So conventional radiation treatment was like opposed lateral beams. So everything in between got the dose. We knew it was getting it. There were big margins. It was fine. We went to 3D conformal, still pretty big margins, but we got better dose conformality. Maybe this was 4 beams, you get a box, right? When we went to intensity modulated radiation, we get a very conformal treatment plan. We started shrinking down our PTVs. Well, what if the patient moves a little bit? With the old 3D conformal or conventional treatments, it wasn't a big deal. There was enough margin that you accounted for that. But we're really pushing the envelope with our PTVs, expansion being so small now. So if they move, they're out of the treatment field. And Dr. Chimura always said that, first rule of radiation is hit the target. So this obviously is not good. So with image-guided radiation, we take an X-ray each day, line up the patient based on that X-ray before we turn the beam on. So we reposition them, make sure they're in exactly the right position, then turn the beam on. So we know that we're hitting the target. So this is an example of a KV image. So this image here is what's called a DRR, or digitally reconstructed radiograph. It's from the CT simulation. The computer reconstructs an X-ray image as if it was taken AP and assigns the isocenter for the, so this is where the isocenter should be. When the patient's on the table, we then take an X-ray, and this is from that GVM plan that I showed you earlier. This is the actual patient being treated. We take an X-ray with an onboard KV imager. This shows you where the isocenter is for the treatment day, and then you can compare. You could either look down here and make sure that the bony anatomy is crossing at all the right points. So you can see here it comes across. This is at 9 centimeters. 9 centimeters. You can also scroll across, kind of make sure they line up appropriately. And you do AP and lateral, make sure in the right position, and turn the treatment on. And then follow-up visits, depending on the site treated, the follow-up schedule varies. Usually 1 month after treatment, and then every 3 to 6 months we'll order imaging, check labs, whatever needs to be done. And then we assess for acute toxicities, which we define as kind of within the first 6 months, and late toxicity. These are some examples of toxicities for breast, prostate, brain, palliative. Radiation is really a localized treatment, so the toxicities really are specific to the site that we're treating. The one thing that I tell patients that happens to their whole body is they get tired, they get fatigue, and that's kind of common across all sites. But otherwise, it's really where are we treating. So breast is going to be skin, ribs, lung, maybe heart for late toxicities. Lung, when we treat near the esophagus, big things, they get pain with swallowing, they may get radiation pneumonitis. Head and neck or head, you're worried about brainstem, spine, optic chiasm, that kind of stuff. But it's really site specific, so part of what you learn as a resident is thinking in those terms.